Good morning. Welcome you all in this session. I want to thank IPDI for giving the opportunity to talk on use of cardiac MRI in the assessment of MI. So, if you look at the graph, it shows that in last 50 years there's tremendous reduction of mortality after the introduction of CCU, but in 2005 and thereafter, this mortality reduction after MI become stagnated. So in-hospital mortality after MI, particularly STEMI outcome, have stagnated despite unique improvement of PCI, reduction of door-to-balloon time, new stent strategy, and appropriate antiplatelet therapy. And it is found that development of heart failure after acute MI and PCI, 1 of every 5 patients develop heart failure in next 5 years. Why this happened? Let's review our pathophysiology. It is found that after occlusion of epicardial coronary artery, within 30 minutes, there are reversible changes in the myocytes, causing edema. And if the ischemia is sustained, there is irreversible injury, which occurs myocyte over 30 to 60 minutes and endothelial cells over 60 to 90 minutes. And this is the jeopardized myocardium after onset of occlusion. And then necrosis of the tissue starts from the endocardium to the epicardium after 60 to 90 minutes. And over 3 to 6 hours, most of the supplied area become necrosed. So this is the schematic diagram showing jeopardized myocardium, salvageable myocardium. This can be detected by MRI, edema imaging, and star imaging or T2 imaging. And if the ischemia persisted, then there is appearance of necrosis that can be detected by LGE. And also, if the prolonged ischemia, there is microvascular occlusion that can be detected in black area. And this infarct containing the black area, this is the microvascular occlusion. So it is found in the literature that showed that the relationship with angioplasty time with the myocardial salvage, infarct size, microvascular damage, and it is found that salvage myocardium is markedly reduced when reperfusion occurs more than 90 minutes of coronary occlusion. And it is interestingly, you can locate if the occlusion, you can open before 90 minutes, the edematous myocardium, and there is infarct. So you can deduct from infarct from the edematous myocardium, you can identify the salvageable myocardium if it opens less than 90 minutes. But if it more than 360 minutes, the edematous myocardium and infarct are almost the same. So virtually there is no salvageable myocardium, both in LAD and non-LAD territory. So there is a bar diagram showing the edematous myocardium start from 30 minutes of occlusion, over 3 to 6 hours the same, but infarct start early in the subendocardium partial thickness, and over time they become full thickness. So if there is myocardial salvage occur when it opened early, but over the time there's very minimum amount of salvageable myocardium. And at the end, microvascular occlusion develops in more than 60% of STEMI patients. So as a clinician, we have some question in our mind after MI that what are the salvageable myocardium, what are the infarct size, what is the location, what is the transmurality of the infarction, and is there any microvascular occlusion or intramyocardial hemorrhage, and obviously what is the global function, ejection fraction, and any complication like thrombus, aneurysm, rupture, or regurgitation. And chronic case, the question whether this patient has viable myocardium or inducible myocardial ischemia. So goals of MRI in post-MI patient, particularly STEMI, to see the assessment of efficacy of primary PCI by looking the salvageable myocardium, and those who are late presenter, the issue of viability or ischemia to guide revascularization, and also risk stratification and other complications. In non-STMI, most of the time, angiographically, you cannot detect the culprit artery because there are almost multifacial disease. In that sense, MRI can detect which area is infarcted. And MINOCA, I mean myocardial injury with normal coronary artery, ACS-like syndrome, MRI can detect whether it is myocarditis or myocardial infarction or Takotsubo or vasospastic infarction. So there is role of MRI in acute MI in different phases, both mostly subacute phase and chronic phase. Acute phase, it is done by echo because echo is bedside test and easily available. So MRI can detect all the steps of ischemic cascade from the ischemia, I mean edema, to injury, necrosis, and even microvascular occlusion. So the goal of MRI is to assess the efficacy of primary PCI, to see the blue area, the salvageable myocardium, and this is the infarcted and minimum salvageable myocardium containing the microvascular occlusion. So we know that MRI is the unique features to detect infarct because of its spatial resolution, and it's validated by histologically, but it's better than even a nuclear study SPECT. Even 1 gram of tissue can be identified by the MRI. So subendocardial infarct many times missed by the nuclear study. And it is found that in randomized study, 5% increase in infarct size contributes to 20% increase in relative hazards for all-cause mortality, hospitalization for heart failure within 1 year after primary PCI. If the more than 4 segments of 17 segments are involved with transmural MI, there is adverse chance of remodeling and future happening of heart failure. We know that 90% of our myocardial blood was supplied by the microcirculation, and this microcirculation is affected by the persistent ischemia causing by perfusion defect. And this is due to edematous endothelium and constricted capillary. And most of the time in cath lab, we found that 90% case TB through flow can be achieved, but among them 50% has myocardial blast and ST segment resolution. Means 50% are not effective or suboptimally effective of primary PCI. And it is found that 1% increase in microvascular obstruction increase 11% of relative hazard for all-cause mortality, hospitalization, and heart failure within 1 year after primary PCI. So MRI can detect and quantify the reperfusion success. This is the inferior MI with complicated pericardial effusion and transmural infarction containing microvascular occlusion, and the lateral MI from the LCX territory containing microvascular occlusion. This is the complication. Just 1 minute. We can detect MR and quantify MR accurately, better than echo, and we can also detect apical thrombus, which is usually missed in many times echo, aneurysm, and also adverse remodeling to plan the surgical vascular reconstruction. And for who are the late presenter, we can assess viability on the basis of 4 parameters: endoscopic wall thickness more than 5 millimeter, and wall motion abnormality, whether it is moderate or mild to moderate, and LG transformative if it is less than 50%, and contractile reserve by dobutamine stress echo. So, who will benefit from revascularization in a patient with LV dysfunction after MI? Those who have more than 50%, like this case of hereditary, they are not non-viable. But those less than 50% chance of improvement, because recovery of improvement of function depends on the transmurality of the infarction. So we can detect inducible ischemia by stress CMR, both by first perfusion and also by the wall motion abnormality, inducibility by dopamine stress MR. Upper row is the stress, always upper row is the stress, showing the hypoperfusion in the inferior territory, and in the rest perfusion there is no hypoperfusion defect. So there is individual ischemia in the inferior segment, whether it may be RC or LCS, depends on the dominancy. So perfusion CMI is the class 1 indication for revascularization, and mostly it is the intermediate lesion, the LCS lesion, showing the lateral hypoperfusion. And like echo, we can see the contractile reserve by low dose, whether hypokinesia improved or not. And in high dose, whether it is paradoxally reduced, signifies there is inducible ischemia. And low dose, it indicates is the viability. So, take home message is MRI is the one-stop shop for answering all the questions in our mind as a clinician. We can assess global function, infarction location, perfusion, as well as to identify the edematous tissue. Thanks for your paying attention.
Thank you, Dr. Ajoy Dutta, for your nice presentation.